Well, with that, I'm going to get out of the way, and we're ready to do our Q&A. Thank you so much.
Thank you, thank you, thank you. All right, let's get into it right away. Hello, NCAN family, and glad to have all of you here. Big congratulations to Marian and Bob and the team of NCAN. 80th conference. Wow, that's huge. So this is exciting. All right, let's get to the question and answer. The first question I received is, news from Alpha trial sounds encouraging. Will it be available for all NET patients or limited to certain primaries? Dr. Mohammed, why don't you go ahead and answer that question? What's the status of Alpha therapy right now, and what disease groups, GEP NETs or all NETs or lung NETs? What's happening?
So basically, alpha targeted therapy is another type of treatment, like the same like PRRT. But the difference that alpha targeted therapy is still in a phase 1, so it's early, very, very early phase. I think it's very promising. The results that we saw at the last NANETS, the North American Neuroendocrine Tumor Society conference, was showing a very, very promising response in gastroenteropancreatic. I think it's very early to judge it right now, but definitely if you have a good somatostatin receptor, you did not receive the PRRT, and you are comfortable to hear more information about it. I referred a couple of my patients to the phase 1 trial, and they had a great response. But again, we cannot really compare both of them right now. I think we still need some time. PRRT already is one of the standard of care. It went through a phase 3 trial showing, definitely a very, very good, robust delaying in the progression of gastroenteropancreatic neuroendocrine tumor, which express the metastatic receptors. I think it's very early to judge the alpha targeted therapy, but definitely it's worth a discussion with our patient to tell them that's one of the options. It's still in the clinical trial. What is going to be in the future for side effects? I think we're still learning about that.
Absolutely, I could not agree more. I think it's just another tool in our armamentarium, and I hope the drug gets developed for not just GI and neuroendocrine tumors, but for other extra GI and thoracic neuroendocrine cancers. But it's too early to say. It's still in the development. Dr. Malucci, next question is to you. So one of our audience members asked a question regarding surgery for stomach. There is some. Are you guys hearing the noise as well? Bob, I think maybe your
other people would like to make it mute.
Yeah, somebody has extra mics on or no headphones, and we're getting a lot of crosstalk. So I don't know if Bob's got his mic on, maybe.
Okay, perfect. I think somebody's microphone was switched on. All right, great. So there is a question regarding, it's not very clear. There's a question regarding gastric neuroendocrine tumor. I would try to simplify the question. Dr. Malucci, can you tell us, when do we warrant surgery in gastric neuroendocrine tumor? This is a very, sometimes can get complex, as there are various types. Can you summarize for us, when do you approach for surgery, and what type of surgery is recommended for gastric neuroendocrine tumor?
Okay, yeah, so I didn't include gastric, so I apologize. So because we rarely require surgery, because gastric carcinoids tend to be extraordinarily low grade, often non-invasive, rarely spread to local regional lymph nodes, and rarely metastasize. And so as such, they are unlikely to be drivers of mortality. So for gastric cancer, there are different variables. We get them into types, type 1, type 2, and type 3. And that has to do with the changes in the physiology of the stomach that is driving then the development of neuroendocrine tumors in that area. So the easiest way to answer that question is that we are more likely and more often to use it in type 3s that tend to be sporadic, not related to either a genetic disorder or atrophic gastritis, a disease of the stomach, and therefore have a less predictable biologic behavior. And we operate on them not dissimilar to the way we operate on other types of gastric tumors. So one would be the type 3s. And then there will be times when I feel like we are operating on the type ones. Those are the ones that are associated with atrophic gastritis or pernicious anemia. It's due to a pathophysiology or an abnormal physiology of the stomach that drives those tumors. But the people can get, so different categories. People can get just ongoing tumors. Like every time we scope them, they've got another tumor. Or we get higher grade tumors. So they start off low grade, and then on future endoscopies, they become higher grade and therefore less predictable. And it's like in a young person, you're like, I don't want to be doing that for the rest of their life. And three would be when someone has complications associated with it, like other complications of atrophic gastritis, like erosive gastritis, gastrin levels that are running into the several thousands. And then more commonly, because I felt like we weren't operating on a lot of the patients that had other side effects of atrophic gastritis, like severe gastroparesis and things like that. But the operations that's required is often done robotically. It is a distal, if not maybe a distal subtotal gastrectomy. It is a really low morbid. The morbidity is low. And in many patients, it can not only eliminate the neuroendocrine risk, but can actually palliate symptoms related to the underlying disease.
Thank you very much. I think that was very comprehensive, and that kind of clears up the clear indications and also those where there is a gray area and we don't really know. And clearly there is role for surgery. As you mentioned, somebody has terrible erosive gastritis, excessive gastrin, or symptoms related to that. All right, sounds good. Let's get to our next question. Dr. Mohammed, should PRRT be used as a treatment of last resort? I presume they meant metastatic disease. What's your take on it?
So definitely, according to the NETTER-1 trial, we use it as a second line now in gastroenteropancreatic neuroendocrine tumor, which means primary either small bowel, which is the mid-gut, was the main trial was on, but definitely we see the same or even sometimes better response in pancreatic neuroendocrine tumor. Patient definitely need to have a good somatostatin receptor, and this is where the multidisciplinary action team come, that in the tumor board, our nuclear medicine radiologists will showing us that most of the lesions in the primary tumor and the metastatic setting having a good intensity, what we call the homogeneous intensity in all the lesions for the somatostatin receptor. So we use it now as a second line in metastatic setting. I would like always to tell my patients that the main purpose of using PRRT is to delay the progression, hopefully keep it stable for a long time, but don't expect a lot of shrinkage when we do our first restaging imaging 3 months after the last treatment. But we use it as a metastatic setting, gastroenteropancreatic now, the second line if you have a good somatostatin receptor expression. I think we lost Shima. Yeah, I think he'll be coming back in a minute.
Hey, maybe you can answer this question because it's come up more and more. Is the use of PRRT actually as frontline? So someone gets a new diagnosis, somatostatin receptor positive, and they've like barely even started somatostatin receptor inhibitor therapy, and they're coming and asking because they want to be aggressive, asking at using PRRT up front. What do you answer to that?
So we have a NETTER-2 trial, which is using that as a second line right now. As a standard of care, definitely that's not the recommendations. We use it in the patient who progress on somatostatin analog. But sometimes we do the anatomical imaging, CT scan or MRI, and then in the bed gallium-68, you see much more lesions. Definitely high burden lesion that we cannot see it sometimes with anatomical imaging. There's some data that treating this patient early more than waiting will having slightly better effects. I don't think we have a good robust data about that. I still use it as a second line if the patient progression to metastatin analog, except if the institution has a NETTER-2 trial, they can include this patient up front in the first line.
For a second.
I think you make it on mute. I couldn't hear you. I'm sorry.
So you pretty much say, so that's what I tell people, is that you tend to use it on either an institutional or a clinical trial.
So Shaman, are you here now?
Yes. Can you hear me, Dr. Mohammed?
Yeah, so the question that Dr. Maria was asking is, are you considering PRRT as a first line? So I shared with her that, the standard of care now is using it as a second line for progressive on somatostatin analog. However, there's a NETTER-2 trial. If you have it at your institution, you can include these patients. And the data for using it as a first line, if you have much more disease in functional imaging than anatomical imaging, is still very early data. I don't think it's a standard of care yet.
Yes, I completely agree. I don't think we would treat Lutathera or any other PRT agent, the frontline outside.
I think you have a bad connection.
Well, it appears to me that Dr. Chauhan is having some internet issues. I'm going to ask Tricia, or who's in charge of gathering the questions, if she would just pose the next question to you.
Okay.
Let me get the questions and send them to Amar.
Okay, we'll be ready in a moment or two. Dr. Maluccio, do you have something that's been asked of you quite often by patients?
I think you are on mute.
Oh, yeah, you're muted.
You mean from a surgery standpoint or from
Yes.
a treatment standpoint?
Yeah, from a surgery standpoint.
Yeah, so I think that the people that come for second opinions are primarily feeling like either the explanation at the host institution has just not been clear on why they are not surgical candidates, or why they just don't get it. But I think that's because most cancer patients want to say, well, isn't getting it out better than leaving it in? And you can totally understand where they're coming from, but that in this type of disease where people live a long time, even in the setting of metastatic disease, sometimes the surgery is just not the appropriate option at that point in time. So I am somewhat opinionated on at least having those words come out of the mouth of a surgeon, as opposed to one of the other members of the team that may not be able to say it, and often will say, oh, you're unresectable, or this, that, or the other thing. So most of the questions come up on, why am I not a surgical candidate? Or are they selling me short because they tell me I'm not a surgical candidate? Or will I ever become a surgical candidate? And I think that these types of conferences are really great at trying to put that in perspective for people, because we all are interpreting the same data. So each of us is just trying to explain it to a patient in the context of their particular case, and no neuroendocrine case really looks exactly like the other.
Okay. Well, thank you for that. Sorry for the technical confusion here. We're going to get through it. Hold on one second. What?
I sent them to Dr. Mohammed.
Okay. Dr. Mohammed, if you can check your email, I think that looks like we sent you a list of questions. If you wouldn't mind.
Sure. Yeah, let me open my email right now. Okay, so can you guys hear me?
Yes, absolutely.
Okay, so the first question is, are all neuroendocrine tumors detectable with gallium PET scan? If not, which one cannot be detected? Thank you. So, in general, we see much more lesions, about 20% more than anatomical scan, which means CT or MRI. We can detect more lesions in the gallium-68, mainly in the lesion which have somatostatin expression. So the PET gallium-68, or the new copper-64 that we have, we call it functional imaging. It's going to measure the somatostatin expression. So if you do not have somatostatin expression in your lesions, definitely it's hard to detect them on the gallium-68. So this was the first question, that all of them are detectable by the gallium-68 or not. And if not, which one cannot be detected? Again, the one which does not express somatostatin receptors. Is Lutathera a relatively new treatment for MedGAD? It's not new treatment. It has been approved It's relatively according to the other treatment, yes, but it has been approved almost more than 2.5 years ago in 2018 after a phase 3 trial was mainly in the mid-gut, well-differentiated neuroendocrine tumor, metastatic, who progress on the somatostatin analog injection, either octreotide or lanreotide. And from that time, we use it in the metastatic setting. The idea after surgery, there is some data showing that removing the primary tumor, especially if the patient has a small bowel neuroendocrine tumor, can having slightly better effects with Lutathera after that. Because the problem with the Lutathera, think about it, it's a targeted radiation. So it can cause a lot of inflammation or what we call desmoplastic reaction. So if that's happening in the small bowel, this patient tended to have more and more bowel obstruction. In some of the cases, it was about 30% of patients. So we usually use steroids in these patients, especially if the primary tumor was not removed. The other question, if primary mid-gut tumor has not been seen with PET scan, just the abdominal lymph node nets, can you perform surgery effectively? So that's depend on what is the imaging showing. If the primary tumor has not been detected, it's called unknown primary, which has been detected in about 25% of the cases. Still have unknown primary. You can do everything, CT scan, MRI, even colonoscopy, upper endoscopy. You cannot detect where is the primary is. I think in these cases, we still need to definitely do the functional scan, may detect some activity in the primary tumors, doing capsule endoscopy, repeat the colonoscopy with ileum exploration. There's a lot of modalities that we still can do, hopefully, so we can detect the primary tumor before we decide in any surgery or treatment forward. I think Shahan is here right now, so he can lead us.
Perfect. Hey, I'm so sorry, man. I have no idea what's going on, but hopefully it goes smooth from here. That was a wonderful answer. Thank you so much. Let's go ahead and let me ask Dr. Maluccio. This is a question that I often hear from our anesthesia colleagues and local oncologists and people from outside, from NotNet Center. What's your take on the risks of carcinoid crisis perioperatively? How do you guys at NOLA Nets prepare for it? What is your advice for patients who are going for any sort of interventive procedures, be it embolization or any sort of surgical procedure, to prevent that from happening?
Okay, yeah, that's actually a great question. So we probably have at least 50 phone calls a year that are me talking an anesthesiologist or an interventional radiologist through the perioperative management of carcinoid syndrome patients. So definitely more likely to happen in people that have a neuroendocrine syndrome and elevated markers like serotonin and 5-HIA. And we have a protocol that is very easy to follow and that we see very little of it, even in the cases where we are doing aggressive surgical debulkings, including liver resections. So if I were to just do my own personal experience, when I started doing these in Indiana, and we were doing a protocol that was kind of an as-needed protocol, I tell people I was just like trying to get those bees back in the hive once they've already left the hive and the carcinoid crisis has started is much more difficult than trying to prevent the carcinoid crisis from occurring or to blunt the manifestation. So we saw carcinoid crises type problems in the operating room far more often in Indiana, where we were then trying to play catch up. Here, we have a protocol in place where, whether or not it be prior to interventional, where you can have it happen just as often and you don't have the same resources as you do in the operating room, but with a combination of an octreotide drip, which has become slightly problematic because of the nationwide shortage, but acting octreotide drip, hydrocortisone given in 100 milligrams, Benadryl, Zofran, you're just blocking H2 blockers, steroids, and octreotide in combination, but that the doses we're using are like 250 mics an hour. So you're using much higher doses than we would think that you would need, but that if you follow the protocol, you're unlikely to have it. If you do struggle with carcinoid crisis, we also have a protocol to get you out of it. And we have mailed that protocol all over the country.
Perfect. Let me throw you just one last curveball. Somebody's getting a dental procedure. Can they get lidocaine? do they have risk for crisis from that? What do you recommend?
They don't. And well, and I probably answer like 200 calls from this. So for some reason, although people in carcinoid crisis can often not respond appropriately to epinephrine, and therefore they have kind of this weird reaction. It's not really an allergy, but that it often is like beware. And then COVID vaccines came out, and all of a sudden they were like, oh my God, what if I have a reaction? Can I take epinephrine? So the dental procedures where you're using epinephrine in the setting of a local anesthesia is completely irrelevant. That is using it in an entirely different way than we are using epinephrine when someone is having hypotension in the middle of an operation. So I will usually have a blanket thing that we send to the dentist, but that I do feel like perhaps the better part of Valor is to just have a consensus statement by a group like NANETS, and just say, hey, this is what we've come up with, so that we don't have like 200 dentists calling us.
Fantastic. And that's why I specifically wanted to ask you this question, so all our neuroendocrine tumor friends here can hear and be reassured. Okay, great. There is a lot of questions regarding COVID vaccination. I don't know if that question was asked when I was offline, but if it wasn't, I'd like to know what's the recommendation at your centers. Dr. Mohammed, you go first, and Dr. Maluccio, what are your recommendations regarding COVID vaccination in patients?
So yeah, I definitely encourage my patient to get the vaccine, except if I know that the patient in chemotherapy like Keptam, or they're having a bad reaction to everolimus, what we call myelosuppression, and they're having low white blood cell, or maybe an extra reaction to PRRT. Some of the patients definitely will have what we call them MDS, which is affecting the bone marrow production of the cells. So if the patient have a low white blood cells, I will definitely be very careful with this patient, because the vaccine has not been tested in this subgroup of immunocompromised patients. But all other patients who are relatively, the immunity is working okay, they are in other treatment, injection or something different, I definitely encourage them to go ahead and get the vaccine, especially the old ages.
Perfect. And what about you, Dr. Maluccio? How is Nolad handling this?
I pretty much agree with everything that he said. We will have a subset. I'm sure that both of you have a subset of patients that have neuroendocrine in the context of autoimmunity. It was also not tested in patients with autoimmune physiology. And therefore, those are the patients where I'm saying, hey, I would take extra precautions until we're pretty sure that you're not going to have a bad reaction to it, because that second dose is associated with side effects. And then I tell people that it's not safe to get it in someone that is somewhat quote unquote immune compromised, but the whole point of the vaccine is to get the appropriate response. And if you're immune compromised, you're still going to be at risk for a worse manifestation of the virus if you get it, and you won't be able to mount the same response as someone that is more immune competent. So the timing of it in the patients that are on active chemotherapy has been what we've done. And then even PRRT, because infusional radiation therapy is associated with immunosuppression, in the patients that have asked about it, I've gotten it at 6 weeks. I've gotten it at 6 weeks, leaving them just enough time to get over the dose, and then a 2-week gap before they get their next dose.
Fantastic.
The second dose was the vaccine was hard. I am sure every one of you had the experience.
Oh, yes. A day or two of chills. But I highly encourage everybody, if they don't have absolute contraindication, to go ahead and get your COVID vaccines. As you can see, all three of us here have gotten ours. That's the only way forward to kind of get out of this pandemic finally. So that next time we can actually meet in a real physical meeting. How fun that would be. One extra point I'd like to add, especially for the booster vaccine, people do tend to get a little bit chills and myalgias for a day or two. So if you know you're about to get treated with, let's suppose, PRRT or something of that sort, try to time it so that you're not feeling sick on the day of treatment, because especially if you're on a clinical trial or sort, you might be excluded from getting treated that day, because we would not be able to differentiate between an infection or booster-related reaction. I have gotten a couple of questions regarding risk management and our risk aversion net patient. I'll try to consolidate that. What can we do in terms of lifestyle, food we eat, exercise, etc., to reduce our risk of tumor progression? And is there a role for fasting and autophagy, and what role does that play? And I would also add, nobody asked this question specifically, but this is kind of in the same realm. Does sugar feed cancer? Should we avoid high sugar diets? So I'm kind of including or clubbing all these questions, lifestyle related questions, in one group. Dr. Malucci, you go first. I'd also like to hear Dr. Muhammad's comments.
Okay, that's a very loaded question. So I am a totally holistic, nutrition person. So what I tell people predominantly is that the fasting thing, I think, although there are health benefits of it in normal life, is not good for neuroendocrine. So I think that that small, frequent meals and not overtaxing the neuroendocrine system that you need to help you digest and absorb your nutrition is more important than any of the health benefits that are touted there for fasting. So that is like an easy question. Secondly, I think that there is really no convincing evidence that even in those patients that have carcinoid syndrome, that for some reason dietary modification is going to change the biologic behavior of that tumor. It may make you more or less symptomatic, but it's not going to make it more or less aggressive. So really, it's about diminishing the manifestations of the disease that are then potentially going to have you either lose weight, diarrhea, quality of life issues, and things like that. And then I have pushed people towards individual diets depending on the type of problems they're having after the operation that they've had, like whether or not that be a bile salt reabsorption issue or some malabsorption related to SSI treatment and things like that. I have said that we are unequivocally, we are what we eat. And the American diet is just not attuned to that. And so I would, instead of having it be like such a major burden, I would just try to embrace the dietary modification that can actually be better for you anyway, than to see it as you not being able to live it up like Americans so like to do. So that's
great point. And what about you, Dr. Muhammad? Any advice in terms of exercise, advice, running advice, or can it make things worse? Somebody asked this specifically.
So definitely, I include nutritionists in our, in our program from day one. So the first visit, I usually make our patient meet the nutritionist as well. And the common question that does any of the food which you're having what we call tryptophan will increase my cancer, makes it worse? Whether, very common food that we eat every day, kiwi, banana, avocado, and all that. I usually tell them there's any evidence it will make your cancer worse, as Dr. Maria just said. It definitely can increase your symptoms, but not every patient is like that. So I just tell my patient, if it gives you a hard time, you're having more carcinoid features, be away from this. Would make your dairy every day and write what.
Okay.
Considering I'm in the mountains, I'm feeling pretty good about my connection.
Yes, I don't know what's going on. Can you hear me, Lucia? Am I back on?
So Muhammad is frozen on my screen, and you.
It will make your cancer worse.
Yeah. Okay. Am I back live on? Can you hear me, both of you? Perfect.
Yes,
great.
It appears that we have your audio. You're frozen a tad.
Okay. All right. At least the audio is there. I'll go ahead and ask final two questions because we are kind of running low on time. The next question I'd like to ask is, can we get, or can a patient get more than 4 doses of Lutathera? And how? And I'd like to club that because there were various questions regarding sequencing. I think we touched a bit about it earlier. How do we pick between Afinitor or CAPTEM or PRRT, and in what order? Looks like Dr. Muhammad is kind of trying to come back. Dr. Malucci, what's the practice pattern in your center? And then maybe I can answer this question.
Yeah, you can do the order of the CAPTEM Afinitor. I think that I've sat at tumor board for a long time. I don't even think I know the answer to that question. So the answer to the can you get more than 4 doses of PRRT is obviously yes, but it depends. There is ample evidence coming out of Europe that that more cycles is not going to be radiation limiting. The issue with it is very individualized, so patient to patient. 2 is based on somatostatin receptor avidity. 3, it's a little bit problematic because the way that we give PRT here is not exactly the way they give it in Europe now. And so our ability to say, oh, we give, additional doses, the way that we would have to do it is that we're using it at doses that are probably higher than they're using in Europe, but that we have definitely used it predominantly in patients that have shown that they have had a durable response to it previously, and therefore it seems like a very reasonable option for them.
I completely agree. I think there is plenty of data of using especially 2 extra doses for sure. The reason why we don't treat patients with unlimited number of doses because our bodies or human bodies can only handle a certain degree or a lifetime limit of radiation. This has been roughly defined, at least in old studies, to be about 1200 millicurie. So that really leaves about, if somebody does get 4 doses, which is equivalent to 800 millicurie of radiation exposure, we can still go ahead and give 2 more doses or full doses at the right time. So certainly, yes, there is role for giving extra doses in the right patient at time of progression, especially if they responded really well earlier. Regarding sequencing, it's a burning question in our field. Nobody knows the answer. As I mentioned earlier, it's a fair, this is a good problem to have. We have multiple second and third line options, Afinitor, we have Lutathera, and multiple clinical trials. So how to sequence between CAPTEM, Afinitor, and PRTs based on the individual patient. Certain diseases are really respond very well to Lutathera. For example, if I have a patient with a lot of bone mets and a lot of pain, I think that's a very good candidate for radiation-based or Lutathera-based therapy. If somebody has liver-dominant disease and there's really no disease, and even within the liver, it's a very limited amount of disease, they might be a great candidate for local regional therapy with really good results. So embolization of various sorts, stays, and bland embolization can be certainly considered in those cases. For very minimal amount of disease, local progression, somebody is very young and you want to probably avoid radiation, Afinitor can be a great candidate. So you have to really look into all these aspects before prescribing a medication. Certain times, certain organ issues might preclude or exclude certain therapies. PRRT might not be the best treatment if somebody has a lot of mesenteric disease. That we might try something else for that first. But again, it's a good problem to have all these options. My opinion is a metastatic disease patient would eventually at some point get most of these treatment, and we don't have the clear data if sequencing one before other really has a big impact. As long as we get the right treatment at the right time, it's a marathon, not a small race. And with that, I think we have time. We have finished our time for this session. It was a lovely session. Thank you so much, Dr. Malucci and Dr. Muhammad. We learned so much. Fantastic. Sure. And to our viewers, I apologize for the technical glitch. Hopefully it'll get better from here. I think we have some excellent speakers lined up. Dr. Del Rivero is going to be coming over. I'll hand it over to you, Bob, and I would stay on the side for my presentation later. Good seeing everybody.
Yes.
Awesome. Thanks very much.